blessed to have Dr. Rogers with us today. And Dr. Rogers, you have such a wonderful background and experience. I'm going to let you introduce yourself.
Thank you. Hello, everyone, and thank you for inviting me to such a prestigious event. I am so honored to be here. My name is Dr. Leslie Rogers. I'm a psychologist, and just a little bit about myself. I grew up in Washington, D.C., Maryland area, where I completed school, undergraduate, graduate to school, and received my doctorate degree actually on my birthday in September of 2018, where I relocated to North Carolina and worked for the Veterans Administration, where I serviced veterans, military, which was a very rewarding experience for me. I loved every moment of it. To then step out on my own and create my own practice, which is where I am today. I have my own private practice in North Carolina. I am also the owner of Mental Health Talk LLC, where we promote dialogue around mental health and overall well-being, and in hopes to decrease stigmas. There's a lot of stigmas around here around mental health and mental well-being, especially mental illnesses. I'm also the publisher and editor of a wonderful publication, the Mental Health Talk magazine, that I am very proud of. That's growing, and we're trying to get it into bookstores, into Amazon and Barnes and Noble and other bookstores. So yes, I do have a couple of projects under my belt as well. Men Suffer Too. I work a lot with first responders and men, the specialty populations. And I use the word specialty populations only to mean that when working with certain groups, you might need to employ a modified approach to therapy, such as working with first responders and men, especially around trauma.
Excellent. And one of the things I know you and I talked about, and I know you focus on, is what is the difference between mental health and mental illness?
Absolutely. That is an excellent question. And it's an excellent question because I think people confuse the two. I started separating mental health from mental illness, especially with attempting to decrease stigmas. Mental health is how we care for ourselves holistically, how we get up in the morning, how we shower, how we go out and go to work, how we're effective on our jobs, how we build meaningful relationships. Mental health is how we take care of ourselves health-wise, right? It's just taking care of ourselves holistically. Mental illness, on the other hand, are diagnosable and treatable illnesses. Diagnosable and treatable illnesses, right? And we're going to get into that a little later on in the conversation. But it's important because when you talk about mental health and people are like, ooh, I don't know if I want to talk about that. What they're kind of resistant to talk about is mental illness. The misunderstanding around mental illness is not mental health. So once we build that foundation about learning, creating awareness around mental health, then we can kind of integrate mental illness and kind of decrease anxieties around that, is my belief.
Okay, great. So let's see, in both cases then, can they both be managed?
Absolutely. Yes, mental illnesses are manageable. They're manageable either with medication or without medication, and by developing certain coping skills. I know one of your questions was, can it be cured or managed?
Yeah, I took that word out because it's like saying, can polio be cured?
Absolutely. And I was going to touch on that. But you know what, Ken? I think it's important to actually keep that word in because some people think of mental illness as a disease, that can be cured. And I've even heard certain cultures, which we'll talk about later as well, can mental illnesses, is it contagious? Can it be passed from one person to the next, right? So I think it's important to use that word cure to, decrease stigmas and myths around mental health and create that awareness around that. I don't use the word cure because, like you said, it implies that mental illness is a disease. And, I think back in the day, there was at one point where where people did believe it was a disease, but there's a medical model in place, a biochemical and biological model in place that's mostly used by psychiatrists in prescribing medication. I would prefer you to use the word managed with a mental illness. We manage our mental illnesses, right? We take care of our mental health and overall well-being, we're able to manage that. So yeah, I think that's an excellent question.
Okay, good. Um, so to better understand, can you give us an example of mental illness, and can you give us an example of mental health?
It's unmuted.
Absolutely. Mental illness, again, are diagnosable and treatable disorders. For example, depression, a mental illness, depression, clinical depression. When you see people who are depressed, loss of interest and pleasure in pleasurable activities, maybe uh, eating, eating disorders, not eating disorders. Maybe your eating has been impacted, less eating or overeating. Hopelessness, feelings of hopelessness, not feeling like the world is worth living in, right? Having no purpose, right? Um, Mental illness, anxiety. Anxiety can be debilitating. And one thing, we use the Diagnostic Manual of Mental Disorders, Statistical Manual of Mental Disorders to diagnose. And one of the criteria is a mental illness. In order to be diagnosed, it has to significantly impair functioning in day-to-day living, in occupational, in academic, and personal settings. So in order to receive a diagnosis, it has to significantly impair day-to-day functioning. So a mental illness is treatable and diagnosable.
So let's focus on mental health at the moment. How would a person know that they may be challenged with a mental health issue?
Again, we go back to that word severity, right? How severe are the symptoms? How severe are the presentations? Um, for instance, we all become down. Dr. Rogers, guys, I become down sometimes. Does that mean I have a mental illness? No, right? But, if it impairs my day-to-day functioning, if I can't get out of the bed, sometimes I just can't get out of the bed. I'm missing days at work, right? It's impairing my performance, work performance. It's interfering with that. Or, I have maybe irrational thoughts around, myself, others in the world, right? How I receive information, talking about, there's this thing called Beck's depressive triad, right? Persons with depression, the information that they receive is negative, right? So everything that comes in that receiving information is all negative. But that doesn't mean, people are diagnosed with depression, anxiety, bipolar, and other disorders that are treatable. But everyone, just some people just go through life, if you will. I've had patients come see me that sometimes don't receive a diagnosis. They just want to learn coping skills around how to better manage experiences that they're going through.
So, I would assume the person, and maybe I'm wrong, maybe you can correct me on this, the person with the mental health challenges might be the last one to know. Is that true or not?
Yes, yes. Some people are functional. You ever heard of a functional alcoholic, or someone that works constantly, and you would never know that they abuse alcohol, right? Some people with mental illnesses are functioning. There's a lot of underreporting. Even with men, when we talk about those gender differences, which I know that's one of your questions, but when we talk about gender differences, a mental illness might go unseen in men because they present differently. It might go underdiagnosed, right? So absolutely, mental illnesses can go untreated if you're so good at what you do, possibly at work, you don't see that there's an issue, there's a problem, right? Or in other environments or circumstances, you don't see that it's a problem until something, either until negative consequences potentially, or you place yourself at risk potentially, or again, because it's interfering so much in your day-to-day living, it becomes apparent. Sometimes mental illnesses are not really apparent, right? Readily apparent.
Okay. Now mental illness, of course, doesn't even, or mental health problems doesn't affect just the person, it affects the family too.
Absolutely, absolutely. the family are, our support system, right? So when we're ill, families have to, kind of care for us. They become huge support system. Whenever I do my interview, I ask, how is your support systems? Who would you identify as support systems? Because they are big on helping each other get through mental illnesses. They encourage you, they're compassionate sometimes. However, there's, families that, don't support mental illness, right? And that's when we talk about the cultural piece as well. But yes, mental illnesses impact families, friendships. Mental illnesses impact friendships as well. Mhm.
And what are some of the, maybe looking for a better word, but what are some of the warning signs that a family or a friend should be looking for?
What are some of the warning signs for what I'm saying?
Warning signs, like how would they, at what point am I as a family member going to be concerned about my family member that I am concerned about? I mean, what is some things you should be looking for?
Absolutely. Are there behavioral changes? Are there, abrupt changes? Are there chronic changes, changes that happen over time? Um, is a person acting out of characteristic from normally than what they used to? What's important, and I want to point this out, children present differently from adults. So with children, there might be anger, irritability. They might be somatic symptoms such as a tummy ache, or I don't want to go to school, or it may be behavioral problems where they're acting out in school. So you want to pay attention to behaviors, right? Because that's a big indicator in what's going on. Is there something going on, right? And if you have questions, if it's an adult, you can encourage the adult to get help or services. I'm a huge advocate for therapy.
Right.
I'm a huge advocate for therapy. You can be compassionate and encourage your loved one to seek services to make sure everything okay. But before that, I will say I always think it's important to get physicals as well, because physicals are a part of it. A lot of medical conditions mimic mental illnesses. Like for instance, I have hyperthyroidism. Hyperthyroidism may mimic anxiety. I have heart palpitations that feels like a panic attack sometimes, right? So it's very important to rule out medical conditions first, and then seek mental health to see if something's going on, right? So
And I would imagine too with the child doesn't know how to mask it, but as adult might. So a child may be more obvious that they're dealing with mental illness issues.
well, sometimes that's missed too, because sometimes you just write it off as a behavioral problem. The child is acting out.
True, that's very true.
Yeah.
Hey, Leslie, good morning.
Could
Leslie,
I,
Yeah. So the child maybe the child could be acting out. So, parents can write it off as, the child is misbehaving. It depends on what's happening in that child's environment. So again, you're thinking of like different presentations, whether they're children, whether they're adults, whether they're men, whether they're women, what's going on, what are the changes going on, what are you seeing? Are the changes concerning, right? Are they concerning for you? And how are you going to get that person the help that they need?
okay, good. And just one second, Mr. Barnes, you have a chance after the discussion to make a
oh,
comment.
I just want to say, I just want to
No,
let you know I was on the line. Thank you.
okay, thank you. If we can just mute, that would be great. I appreciate it. Thank you. Okay, so Dr. Leslie, one of the things I know you focus on is there is a difference between men and women. And can we discuss what is that difference and with mental health issues and why?
Absolutely. So there's a lot of let's start with prevalence rates. Research shows that prevalence rates are significantly different for men and women, and women tend to report more. Research shows that women attend therapy more, right? Women attend therapy much more than men. And although men do attend therapy, right, sometimes there's underreporting, underreporting in symptoms. there are differences in symptoms between how men report or show up and how women do. For example, we may misdiagnose men based on their presenting when they do show up in therapy, as opposed to diagnosing with depression. Maybe we'll diagnose with an antisocial personality or bipolar or schizophrenia or something else, right? So there's misdiagnoses potentially in men because of presentation, and also underreporting. Men report differently, especially with depression, depressed symptoms. Men display more externalizing behaviors, more acting out, more risk-taking behaviors, as opposed to women, more internalizing behaviors. And then you get to the stigmas, right? The stigmas around men, right? And those men are on here, culturally, there's a lot of cultural differences, on the platform today. What do your cultures say about men and mental health? Is it a sign of weakness? Right? I often tell men, actually, vulnerability sometimes is a sign of strength, right? But depending on how you were reared and how you grow up, you might have a different perspective. For example, I'm a Black woman. I grew up in a home with Black men. In my family, Black men had to work. They didn't have time to deal with mental illness, right? So it went unnoticed. And that means that, statistics are often skewed because men are underreported, especially when you're talking about trauma. Men really report trauma. Now, I believe it's increasing, right? But I still believe the numbers aren't, accurate when you present trauma and gender differences. So there's a lot of difference between, and we already talked about children. There's a lot of differences in reporting and how these special populations, I'm going to say unique populations report. And it's based on child rearing, how you were raised. It's based on how your families, it's influenced by how your families dealt with mental health, if they even talked about it. There's many people that I ask, how was mental health handled in your family? And it wasn't talked about. It influenced on how families deal with men in mental health, and how you're responded to. Were you validated or were you invalidated when you came forward, or when you thought about coming forward? So yeah, there's a lot of gender differences in the way you present in mental illness and mental health.
Is that different in the generations too? I mean, I can, as an older man in my younger days, I was always, as a man, you could not have any mental health issues because that would be a sign of weakness. So, and they'd always say, get over it, get over it.
Yeah.
Is that still the same case today?
Absolutely. I think it's just a fear of not understanding. Again, it's what are the myths that your families grew up with mental illness, right? I think it's starting to shift now, because now mental illness is it's talked about more. I mean, you get on different platforms, everybody's talking about mental illness now, as opposed to when we grew up, and some of you on this platform, it wasn't talked about. It was a sign of weakness, and it's that fear factor as to, if I disclose that I have a mental illness, what does it say about me? If my child has a mental illness, what does it say about my parenting? What does it say about me as a parent, right? Those negative evaluations, or the anticipation of being negatively evaluated because I come forward with a mental illness, or because I talk about my family having a mental illness. And I think it comes down to anxiety, anticipated anxiety around, what is that going to look like? What are people going to say about me? Right. And we talk about those stigmas, you talk about those organizational stigmas, right? The societal stigmas, the family, cultural stigmas, around mental health. It's important to understand those.
Right, absolutely. And does every mental health situation need professional help?
So I don't, again, we go back to that severity, Ken. How severe is it? Is it severe? And again, I'm an advocate for therapy. I think that therapy can be beneficial even if there's not a mental illness crisis, right? So to answer your question, it depends on the severity. Does mental illness need professional help? I'm going to say yes. I think that everyone, even without a mental illness, I think, again, therapy has its benefits.
The problem is too that not all therapists are good therapists.
You know what? Let me go a step further than that. I think that all therapists aren't competent in specialty areas. So it's important for persons to do their due diligence and do their research around what therapists are competent in. For instance, when I was working at the VA, which was my first, because when I came into therapy, I thought everybody worked with trauma, right? But when I was working with the VA with veterans, it was then that I realized, well, wait, not all psychologists are competent in treating trauma. And that's okay, right? You have to be comfortable with not being competent in certain areas. For example, I don't treat eating disorders. So if someone comes to me with an eating disorder, guess what? Dr. Rogers has to refer them out because I don't treat eating disorders. So I would be a disservice to them, right? So being comfortable with not what you're not competent in. So I think that for this, I think that to say that uh, all psychologists or all mental health professionals are not competent in every single disorder. So you should research, yeah.
That's a good answer. The thing is too, what we oftentimes preach as advocates, and preach is the wrong word, what we encourage as advocates, is the fact that if you're going to a medical doctor, or in this case, a therapist, and you don't feel like you're getting the right proper care, it's okay to end it and find another.
Yes, absolutely. And I tell people sometimes you can go in because of those preconceived biases, which is why you should understand what your how you define mental health and mental illness, because you can actually go into the therapeutic relationship and sabotage it because you think it's not going to work anyway, right? Or, if you go into the therapeutic relationship, give it an honest chance and it's not working, you do have the autonomy and the power and control to switch to someone else who is a better fit.
And the other issue is, I would assume too, that just like a medical doctor, a therapist can misdiagnose somebody.
Absolutely. And that's what we talked about earlier about men as well. We can misdiagnose men, especially. But yes, we don't always get it right, guys. We go by what you all tell us. We go by how you present and what you guys tell us, right? So it's a collaborative approach. We don't just, I'm going to say I don't just go in diagnosing, right? I go in and build a rapport first to understand the clinical presentation and understand what's going on so that we can get it right. And you have some models that don't even diagnose. The purpose of diagnosing is to better understand what's going on so we can provide treatment and a treatment plan, right? And for medication and et cetera. Some people, I think that, diagnoses sometimes can be enabler, if you will.
Mhm.
I believe that diagnoses sometimes can interfere with growth and development, mental growth and development.
Mhm.
But again, the purpose for diagnosing persons is so we can develop treatment plans, and for insurance companies, right? Insurance companies, the purpose for diagnoses is so that we can understand and treat the person, and for insurance companies, right?
The one thing that I am always concerned about is a pill is not always the answer. But
Yeah.
oftentimes pills are too often used. It's a Band-Aid as far as I'm concerned.
Yeah, you're right. So here's the thing. When I do my treatment plan, I give a patient an option, to contact a psychiatrist to see if they are um, an adequate candidate for psychotropic medication. However, they have the power to say no. Um, and Ken, so sometimes patients do need medication to kind of create that balance, especially when there's some type of chemical imbalance, such as with depression or bipolar, right? Sometimes managing it alone without medication may be challenging, right?
Mhm.
Um, but that's what the psychiatric support is for, to better understand that education around medication. And there's so many different types of medication out here now. There's dual medications that work not just for one, but more disorders. And but sometimes it's necessary. Not in all cases. Not. I have patients that come to me that aren't on medication, and they're managing. There's that word managing, right? They're managing their mental illness. However, sometimes it's challenging to manage it alone without medication.
Understand. So can you define what is professional care? What is professional help? What is a professional?
Absolutely. A professional is a licensed clinician. Someone's licensed to provide mental health services, behavioral health services. And it can be from a master's level clinician all the way up to a doctorate level clinician. That has there's various disciplines out here that and various models out here that help with mental illness. So it's a professional person, a licensed person that is licensed by a licensing board, right? To provide behavioral health services.
Okay. And so now where am I going to find the right person for me to go to?
Oh, these are excellent questions. Community, your community is always huge. I always encourage people to go to their insurance companies. If you have insurances, insurance companies provide you with a list of professionals. I want everybody to write this down if you don't have it. Star 88. And I don't know, you have to look in your country, your respective country, to see if there is a crisis line or a mental health line. But here in the United States is star 988. Star 988. Right. So your country might have a crisis number or a mental health number too for information. Also, you can community resources you can look into, such as groups. Groups are evidence-based approaches to, if a person don't want to be in individual therapy, they can do a group. A group is just as effective. It helps to build meaningful relationships. It helps to validate and normalize experiences because you're around others with similar presentations. But information, you Google is your best friend. You can look on.
It's not always your best friend, but it's a
Well,
start.
not
It's a
always,
starting point. Yeah, right.
not always. You can Google something and find out what's in your area, right?
Right. Absolutely. So let's talk about one particular area I know that's that you focus on, and that's suicide. You even have is it a webinar that's coming up in a couple of weeks on that? Right.
Absolutely. So I have a class coming up, Building Awareness Around Suicide, that's coming up on March 27th at 7:00 p.m. Eastern Standard Time.
Okay. So what is the difference between suicidal behavior and self-harm behavior?
Absolutely. So suicide is in it what itself. A person kills themselves or a person takes their life, right? Suicide. Self-harm behaviors is because a person engages in self-harm behaviors, such as most popular, such as cutting, burning self, or doing anything engaging in self-injurious behavior. May not be an indication of suicide, may be a cry for help. Most often self-harm or self-injurious behaviors are a way to mask internal pain. It could be from a trauma. It could be from the person can be depressed. But it's not necessarily an act of suicide. Now, I'm not saying that it can't be harmful, because it can potentially end your life by accident, but the person might not go into it with the intent of ending their lives. So I will say this because you asked this question, Ken, which I think is very important for you all to know. I do think it's very important to ask the question, if you think someone is at risk, are you thinking of killing yourself? Not, are you thinking of harming yourself? Because again, harming yourself is not the same as killing yourself. So it's really important to just ask the question. I know it might be uncomfortable, it might be anxiety provoking to the response that you might receive, but I think that the other person may appreciate that too. Are you thinking of killing yourself? Not are you thinking of harming yourself? That's a totally separate question. You can ask that question, but if they say no to are you thinking of killing yourself, then you maybe can follow up with are you thinking of harming yourself?
Okay, that's a good point. And I know with mental illness too, oftentimes, and maybe people who don't have mental illness, they're mad at themselves. They're upset at themselves, so they're going to harm themselves. I worked with an individual every time he felt he had done something that was not proper, he would self-harm himself because that was his way of penalizing himself for what he had done. So yeah. So can you talk about a little bit more about what may be, let's focus on suicide in this case. What may be some of the warning signs? Maybe to a family member? Could it
Yeah,
even be for the person thinking about suicide?
absolutely. And so first we need to, I want to answer the question, are there warning signs? Right? Are there warning signs? So I like to use, when I use terms, and I use my terms wisely, prevention versus awareness, right? I really don't like to use the word suicide prevention because I believe that it puts a lot of responsibility on a person if a person successfully suicides. Like, for instance, if I can't prevent someone from suicide, can you imagine the guilt that I may feel? Um, so there are warning signs, right? But sometimes warning signs are subtle and they might not be readily available or readily apparent, right? Um, there are warning signs, but sometimes they're not readily available or readily apparent. So it might go missed. And I believe, this is Dr. Rogers talking, I believe that if a person really wants to kill themselves, they're going to do it without you knowing it, right? Um, and if a person wants help, you might see more signs. So what I did some research and I looked up the National Institute of Health in 2024, and these are some warning signs talking about wanting to die, great guilt or shame. This is the person that's thinking about suicide, being a burden to others, feeling like they're a burden to others. I don't want to be a burden anymore. Feeling empty, hopeless, trapped, or not having a reason to live. The person is extremely sad, more anxious, agitated, or full of rage. Feeling unbearable, emotional, or physical pain. Uh, uh, and that's a true statement. A lot of folks that's in chronic pain, a lot of veterans that I worked with that was in chronic pain considered suicide. Um, Changing behaviors such as making a plan or researching ways to die, right? Withdrawing from friends, saying goodbye, giving away important items, or making a will. Taking dangerous risks such as driving extremely fast, displaying extreme mood swings, eating or sleeping more or less, and using drugs or substances. And if any of these warning signs that you guys have seen, I would encourage you guys to seek help immediately. But these are warning signs, some warning signs that you may see in individuals thinking about killing themselves.
Okay. And I want to open this up for people who may have some questions, but just let's touch on a couple other things. So if we as a family member see some of those warning signs, what are we going to do?
Get help immediately. Encourage the person to go to the hospital for evaluation. And sometimes that's a disappointing within itself because you'll have loved one say that, tell you they're thinking about killing themselves, but once they get to the hospital, they say, no, I'm not thinking about killing themselves. And guess what? The hospital releases them. right? So it's a bit frustrating because then what do? Then you as a family member feel helpless. Like, what do I do, right? So it's important to be compassionate, supportive, to be validating. I understand, help me understand what you're feeling, in this moment. What can I do to help you feel better? Sometimes listening is the best way to deal with, someone that's in a crisis, listening to them, supporting them, being compassionate, non-judgmental. Non-judgmental meaning, oh, for during COVID, right? During COVID, several persons, had suicidal ideations. Oh, well, it's COVID. What are you thinking about killing yourself for? What are you sad about? Try not to invalidate that person. If they're feeling a certain way, that's their truth, right? It might not be how you feel, but it's how they feel. So it's important to work to understand what they're feeling in the moment so you can understand how to support them and offer them that non-judgmental and compassionate support as a loved one.
Great, thank you. So I've got one more question for you, and what is what's your advice for good mental health?
Absolutely. Self-care. Those that follow me know that I am huge on self-care. Self-care meaning, and it's different for everyone, but self-care meaning ways to love yourself. And, doing something special for yourself. I often say if you do something special for yourself, it's very rewarding as opposed to expecting someone else to do something special for you, because then sometimes it ends in disappointment, potentially, right? So doing something special for yourself. Mindfulness, meditation, and relaxation with deep breathing exercises are excellent evidence-based tools to reduce anxiety. It has health improving benefits, physiological benefits, mindfulness, meditation, and relaxation. It allows you to seek calm during stressful times. It allows you to think clearly, open up your mind, and sit with those negative emotions and understand them so you can be better communicators. Sometimes we don't have the words to communicate what we're feeling at a certain time. So, mindfulness meditation allows you to sit in those uncomfortable situations and better understand yourself so that you can communicate what you're feeling to others. There's a lot of tools on YouTube. YouTube, yes, I use it a lot in therapy. A lot of tools around mindfulness meditation. You can look up mindfulness meditation for anxiety, mindfulness meditation for sleep, mindfulness meditation for depression, guided. The word guided, add the word guided to it. You have somebody walking you through these tools, and slap on some headphones at night to help you sleep. It helps promote sleep. Or you can do it while you're driving in your car. You can do it while you're sitting in a meeting. You can, once you learn, right, the benefits of it and learn how to engage in these tools. There's a lot of tools around mindfulness, meditation, and relaxation. And I encourage you all to make it a part of your regular living. If not every day, every other day, maybe once a week, right? And make it a routine, a practice, and you will see the rewards of it. I do it faithfully.
Thank you, thank you. I'm going to actually look that up as soon as this meeting is over and start watching some of those YouTubes.
If you're a beginner, add the word guided again. If you're a beginner,
Okay,
guided.
okay, sounds cool. Thank you so much on this. The subject could go on all day long and maybe all week long. And I know this is not the end of, we're hearing from you. We're going to have other things coming up from you also. I want to open up to questions. If anybody has any questions for Dr. Rogers, please do it now. John McFarlane, I know he has a question.
I was actually looking to see whether Mr. Barnes was going to come in first, as he'd.
Okay.
But,
Okay.
Dr. Rogers, two questions, one of which may be hypothetical. Is there any proof or any suspicion that bipolar can be familial?
Yes. Oh my gosh, that's an excellent question. You're talking about heredity now. Yes,
Yeah.
absolutely. So there are heredity components, right? genetic components to mental illness. Bipolar having one of the largest genetic component, right? And these are based on twin studies, right? So bipolar having the largest genetic component. A mother has bipolar, then the child is highly at risk for developing bipolar, right? The second largest genetic component is schizophrenia. Bipolar is the highest, and schizophrenia is the next highest, and then depression. Depression also has a genetic component. And it's actually in my magazine, I have statistics, and I have that genetic component for bipolar, schizophrenia, and depression in issue 2 of my Mental Health Talk magazine. We talk about that. But absolutely, and I'm glad you asked that question, is not contagious. You know, bipolar, schizophrenia, and depression aren't contagious, but there are strong genetic components.
There is also, I believe, some evidence to show that substance abuse can actually trigger latent schizophrenia.
Mm-hmm. I'm not really familiar with that evidence. I'm sorry. And you're saying substance abuse can trigger schizophrenia. Well, what are you talking about? Hallucinogens? Hallucinogens can mimic schizophrenic behavior, right? Because of the psychosis.
Yeah. The last one I wanted to put to you is, where do you see CBT fitting into the jigsaw?
Cognitive behavioral therapy?
Yes.
Absolutely.
Sorry.
I use CBT. I use cognitive behavioral therapy also. You know, it helps to challenge irrational thoughts, you know, especially if you go through trauma, you know. Okay, so I had actually, and I'll talk about this now really quickly, because I think this is important to know. So when we were talking about earlier, there is models such as the medical model, you know, which is often used by psychiatrists, but we as psychologists often use the biological model, the behavioral model, the cognitive model, and a psychodynamic model. The behavioral model assumes that all maladaptive behavior is essentially required through one's environment. Therefore, the priority is to change behaviors as opposed to identifying the cause of dysfunctional behavior. The cognitive model, such as CBT, focuses on cognitive distortions, right? Or irrational thoughts. And it focuses on to kind of create alternative thoughts to challenge those irrational thoughts, right? And then the psychodynamic model, based on Freud's theory, goes back into childhood. Childhood experiences shape, you know, mental illness, etc. So CBT helps to challenge that. When a person goes through, for example, when a person experiences sexual trauma or trauma as a child, then maybe CBT would be used to challenge those irrational thoughts of I'm inadequate, I deserved to be victimized, etc., that they develop over the years as they grow up. And then psychodynamic may say, well, children repress these memories when they're young, but when they grow up, there may be triggers that help these memories seep out, and then you employ cognitive behavioral therapy. So I'm an integrative psychologist. So I sometimes go back into childhood based on that psychodynamic model, and then over time slowly integrate other models such as interpersonal psychotherapy or cognitive behavioral therapy. And cognitive processing therapy, John, is another one. That's a evidence-based trauma therapy that is borrowed from CBT to challenge those thoughts for people that have experienced a traumatic event. Excellent question.
Dr. Wilson has her hand up.
Yeah. Thank you, President Masson, and thank you so much, Dr. Roger, for this insightful presentation. Back to the link between mental health and the community
frozen. I'm
service.
trying to get it from unfrozen.
I'm sorry. What was
yeah, can you hear me? Yeah.
Yes, I can.
Yes, yes, we can.
Okay. Back to the community service issues and the mental health. I'd like to ask you about the external pressure during the wartime and the economic crisis. The mental health aids can change the perception of the problems in our community. what are the simple tools for the advocates or the people who work in community service they can use effectively to change the perception of the people in stress? Can you suggest certain programs or certain tools, simple tools, to help or to improve the mental health of the community?
Yes, and did I hear you say earlier when you were asking that question, did I hear you say something about war?
Yeah, about the war here. I think next to our borders, because I live here in Egypt, and we have a war in Palestine in our borders. So we have a lot of refugees, a lot of people in stress, and also economic crisis all over our community. So we need simple program we can work on to improve the mental health of the people.
Absolutely. And, you know, to respond to that, I'm actually volunteering for mental health for the Palestinian and Israeli and war. And,
Yeah.
you know, the best course of action is supportive approach, being supportive, right? Being supportive, being compassionate, being validating, right? Normalizing the experiencing, being active listeners, right? Being able to listen actively to what, because you know these folks are going through traumatic times, right? And I think it's easier to be compassionate and validating as opposed to and teaching them mindfulness techniques to be in the moment and bring down, because they're hyper vigilant right now, right? Hyperactive, hyper vigilant, right? So teaching them skills to, you know, come back to that natural relaxation, relaxing state while in difficult environments, right? So the best approach, I believe, is offering compassion, offering resources, of course, any resources that you guys have. Did you say you were in Israel?
Yeah.
Where you? Yeah, I have.
Egypt.
Oh, okay,
Yeah,
because
yeah, yeah. Yeah, we
I
are in Egypt. This is
okay.
our border. So we have many refugees from both parts, from both
Yeah,
sides. Yeah, we receive a lot.
yeah,
And
because I was
also we have here a sense of irritability in our community and anxious. All of
absolutely.
people are anxious here. Yeah.
And I was going to say, I do have.
Can we do a certain program? Yeah, can we do a certain program from Rotary to support people?
Yeah, so what I would suggest is that to better understand your needs, we talk offline. However, I do have resources because, again, I do volunteer for a company that supports the war. However, I would prefer to talk offline about this. But first and foremost, I want everyone to hear this. It's important when you're dealing with persons in crises, situations, where they are hopeless. And, you know, the purpose, you know, purposeless and hopeless is to be active listening and offer compassion, empathy, and understand what they're going through. Validate. And when you validate, repeat. So what I'm hearing is that, you know, you feel like your parents are going to die, or you feel like you're never going to see your family again. Is that what I'm hearing? Right? Validate what they're saying to you with empathy and compassion, right? And then teach skills such as mindfulness, meditation, relaxation, and deep breathing skills so they can ground themselves. That's called grounding techniques, right? Especially when talking about anxiety, you know, teach them grounding techniques, right? And again, you guys can look up YouTube and look up grounding techniques for anxiety, right? Because these are things that they can do if they have headphones. They can put headphones on and they can listen to it themselves, and that'll drown out that external noise, right? While helping them engage in tools, beneficial tools that may help them kind of come into the moment and relax and decompress and things of that sort. Monica, is that Monique?
Thank you.
Monique is from Uganda.
Thank you so much for your question.
And we need to get you in
Thank
touch with Dr. Wilson. I think it would be good to get you both connected.
Hi, doctor. I'm Monique from Uganda. I'm a stroke survivor. How would I know stroke is not a mental health problem, but the anxiety that comes with the slow recovery sometimes is sickening. How would you advise people with brain injuries to deal with the delays and the comparisons between the previous life, the anxiety that comes with the slow recovery now?
Absolutely. So of course, the anxiety that comes with being a stroke victim, I would imagine, is prevalent, is existent. You know, having a stroke, then a risk for having another one is likely, right? Sometimes. And that anxiety as to the unknown, whether you're going to have another stroke or when is it going to happen, et cetera, right? So recognizing those anxieties and understanding that it's normal to have those anxieties. Getting in contact with, keeping in contact with regular visits, doctor visits, physicals, getting, maybe becoming engaged with a support group, someone with similar history, similar medical conditions, creating awareness around prognoses toward your medical condition, right? Developing a support system, someone who can support you during this time. And also, you talked about, I think you said about memory and things of that sort. Again, you know, obtaining resources that can help promote memory and promote engagement and stimulate, you know, your brain so that you can retain as much functioning as you can. I'm not sure what's lost during your stroke, but understanding what resources are available that can help you stimulate your mind and recover to encourage recovery. But support groups are always great. I don't know where you are, what that may look like, but support groups are always great because you're around your peers that's also validating and normalizing your experiences.
It's good. So, and you know, some of the thing too, and part of your messages too, some of the things you go through is normal. I mean, it's normal part of life. Anxiety is a normal part of life. Depression is a normal part of life. You know, dealing with stress is a normal part of life. And once again, it comes down to your whole ideas with, you know, having good mental health and working on your own mental health, because everybody's going to go through that at some point in their life.
Right. And remember, anxiety is the fear of unknown. Anxiety is the fear of unknown. And there's healthy anxiety and there's unhealthy anxiety. You know, we have to have a little bit of anxiety in life, right? We can't go throughout life without having some anxieties, right? But, you know, there are also healthy anxieties as well, unhealthy anxieties as well. So being able to understand and differentiate between the two, and you want to create a balance between the two.
And the other thing I wanted to touch upon, just going back to suicide, if there's no other questions, it's not only the person who died from suicide, but it's the family who experienced that now is gone into some sort of a therapy situation that they need at that point.
Yeah, yeah. You know, suicide is a tough tough topic that a lot of people don't like to talk about it. So I will, you know, I was with federal law enforcement for 25 years. And, you know, suicides in law enforcement are high, right? And I remember writing my master's thesis on law enforcement suicide. And as I was writing my thesis, about 6 federal agents committed suicide while I was writing my master's thesis, right? And when I went to go turn my master's thesis in, they pulled it because they didn't want that to become public knowledge, right? So it's a tough topic to talk about. It's scary. How do I prevent it, right? Right, going in with that prevention mindset, how do I prevent suicides? Which creates a lot of responsibility on families, loved ones, organizations, right? It creates a lot of responsibility because when you don't successfully prevent it, now what? What's next, right? So education is key. Education is key to know the warning signs. Education is key to know when your loved one or child or partner or friend is deviating from normal behavior, what you know is normal, right? For instance, and sometimes that can go unnoticed. You know, I'll give you another example. We had a colleague to commit suicide, and when we did the suicide autopsy, according to his spouse, he didn't do anything out of the normal. He retreated to the basement as he always did. But when you think about it, was that a warning sign? Right? Because he went to the basement all the time. That's where he worked. So she didn't think anything of it. But what he was doing, once we really digged into it, he was withdrawing from his family. So, you know, sometimes it's not, you know, to take on that responsibility, sometimes it's not readily apparent if the person is suicide. So the best course is to ask. If you think anything has changed, ask. Are you thinking about killing yourself? And no matter how uncomfortable, and you can even disclose that. I know this is uncomfortable for you. It's uncomfortable for me. But this is important. Are you thinking about killing yourself? Right? Because then in that moment, that may give you the power and control to help that person get the help that they need.
John?
Yeah, Doctor, one thing that you've actually highlighted, which you won't realize, that some of us here actually also work with loads of people with physical problems as well. And I'm just suddenly realizing, and I think Mona's going to actually nod her head in agreement in a moment, that we need to be looking more with the support groups that we help to the psychological side, because a lot of the people that we're dealing with feel they are a burden, that they are a nuisance, that they've got no self-worth. They've got a, you know, they may have had a stroke, they may be cerebral palsy, they may be Parkinson's, they might be Guillain-Barré, whatever it might be. But the support groups which are looking after them and which we interact with, I think are going to have to look a bit more at putting another pillar into their foundations, which is actually looking at the psychological side of how to help those people.
Absolutely. And if you think about it though, John, you know, even people with dementia, right? You know, their power, they're being stripped of their power, right? You're once independent, you're once able to provide for yourselves, you're once able to support yourselves, and now you're, for some, totally dependent on others to take care of you. Oh my gosh, can you imagine that type of burden, right? Felt, right? So maybe the easiest is to not live anymore. And I have people that say, you know, I wish they're not suicidal. And this is another thing. You can have suicidal thoughts, but you're not suicidal. You don't have the intent. We as psychologists look for the acuity and the intent. Do you have the intent to harm? So you might have suicidal thoughts, meaning, oh my gosh, I'm so overwhelmed. I just wish God would take me away. I wish I wouldn't wake up in the morning. Just please take me away. Do that mean that you're going to kill yourself? No, it doesn't. It just means that you're tired and it's frustrating because, you know, you have no, you believe you have no control, right? And then there's those persons that have an imminent threat to harm, to kill themselves, right? Do they have a means, right? If the person goes home, do they have, like, are they on medication? Can they use medication to kill themselves? Which is women mostly use medication or less lethal means. As men, research shows are higher than women in committing suicides. You guys know why? Can anybody answer that? Why is men higher? The rates of suicide in men higher?
Well, sure, if I remember correctly, the death rate in men, that there's the biggest killer of men under the age of 35 is suicide.
Right, but why is it higher? Why are men's suicides more successful than women?
Self-nurturing in the female? I don't
Because
know.
they use weapons, because they use guns, because they use weapons. Men
Yes.
then will kill themselves with a gun because they want it over, done. Whereas sometimes with women, it's a cry for help. They don't really want to die. They just want help. They want the pain to stop. So it might be less lethal. Men use a more lethal means. So the question is, if somebody's talking about suicide, do they have a means to act? Do they have weapons in the house? Right? Do they have pills in the house? Have they ever past behavior? Might be the most indicative thing. Have they ever committed suicide before? Do they have a family history of suicides? Like, did a mother commit suicide? Did a father commit suicide? Do they have a family history of substance use? Do they have a history of substance use? When you're thinking about, when you're asking whether or not this person is likely, if there's a risk, then these are questions that you need to ask. These are questions that you need to know.
Dr. Durante in California made this comment. She said, Dr. Rogers, this is a valuable insight. I also like to add that it's critical to prioritize seeking help if experiencing suicidal thoughts, irrespective of cultural norms or expectations.
Yes. So another important question that I asked on my clinical interview, are you a religious person, or what do you believe? What do your religion say about suicide, etc.? Because some cultures praise suicide, such as Islamic cultures, right? Some, I'm not saying all, but some cultures, as martyrs. You guys heard of martyrs, right? So suicide, what's the end result? Is there going to be a reward if you kill yourself? If you kill yourself for your culture, right? It's important to understand cultural differences, and that's not only for suicide, that's for mental illness. For example, some cultures believe, even some, Hispanic, Black cultures, etc., believe that psychotic symptoms may be manifested by demonic forces. Right?
Yeah.
So those cultural differences as they relate to mental illness and as they relate to suicide, religion, what is in my culture, if you commit suicide, you die and go to hell. So I don't want to commit suicide because I want to, I want my life to live beyond after death. Right? So what do your culture say about suicide? What does your culture say about mental illness? What do your culture say about psychosis? Like hallucinations, delusions, and stuff like that. It's important to understand it, and it's important to understand that when working with or around other people that have these experiences. Ask questions is the best way. Ask questions if you don't know.
And Masinga in Malawi, he makes this comment. I feel that most important thing to know is that the cause of the anxiety or emotional disorder in an individual. That gets back to my thing about the pill. Yeah, maybe the pill is good for the moment, but you've got to get to the cause of it.
So medication actually, so imagine this, Ken. Imagine, I go based on stability and instability, right? Mental stability and mental instability. If you're unstable, right? Say like a person has bipolar and they're unstable, right? Therapy alone might not be as successful. So maybe they need to get on medication to stabilize them enough so that I can do my job and teach them skills to cope and etc. Right? And then, maybe if they're stable, medication, like in some cases, depression, anxiety, people aren't on medication for the rest of their lives, right? Think about least severe to most severe. Some people need to be on medication for the rest of their lives. And some people can be without medication. So it depends on the purpose of the medication and the need, that biochemical need. Is there a biochemical need for medication, right? And again, everybody that goes to therapy is not on psychotropic medication, right?
Okay. Yeah. And but it's still, I mean, maybe it's physical or mental. that you have anxiety. I know sometimes I'll have anxiety, I'll have no understanding why I'm anxious about, but do you think there is a cause for anxiety?
So that's that nature nurture phenomenon, right? When you talk about nature nurture and you talk about, and that's with anything, nature nurture, right? So anxiety does have a genetic component as well. And I believe that sometimes it can be learned behavior. You know, we as parents, when we raise our kids, we can model anxiety, right? We go outside with our child and a friendly dog, a little tiny dog, and I've seen this happen, guys. A little tiny dog come up and the mother or the dad is like, no, don't touch him. He's dangerous. Right. And now you go through life afraid of dogs. Right.
True.
Or you know, sometimes we can project, and this is what I'm saying, sometimes we can project our own anxieties on our children, right? Based on our personal experiences, but it's not the experience of the child.
True. Very
Right?
true.
So that child grows up, you know, with anxiety. And I'm not saying it's all cases, but what I'm saying that I believe that nature and nurture play a role in anxiety. But then you have those more genetic component disorders such as schizophrenia, right? You can't learn how to be schizophrenic.
Or could it be caused just by a chemical imbalance in your system?
It could be genetics, chemical imbalance.
Yeah.
Yeah, it could be. And schizophrenia isn't really prevalent until the person is in their like 20s. Like, you know, most of the times, like when I was working at the university as a university counselor, a lot of those kids, you know, that's where I saw most psychosis working. And, you know, usually when they're, you know, in their 20s is when it's really prevalent. You might see it, and I'm not saying kids don't go through psychosis, but it becomes really apparent when people are in their 20s.
And that's a whole nother subject we can deal with in another time, but diagnosing schizophrenia is not easy diagnosis. Bipolar is a long process of diagnosis. So and we can get into that in another time because that's whole something else that we can discuss. If nobody else has another question, and Dr. McRae says, yes, we need a part 2. I'm sure there are people here in the room, or maybe people that are watching on Facebook that may have some questions for you. How are they going to get in touch with you?
Yes, I am all over social media. I am on LinkedIn as dr.leslie-rogers, Instagram, TikTok, Dr. Leslie Rogers, dr.leslie-rogers. My email, I put it in the chat, but I will give it to you guys again. Please reach out to me, guys, and keep in touch. It's Leslie, Leslie, at mentalhealthtalk.live, LIVE, Leslie at mentalhealthtalk.live, LIVE. You can also go to my website, which is, and I'll put this in the chat too, www.mental, and you can contact me through here too, mentalhealthtalk.live. And I would love if you guys do go to my website and check it out, www.mentalhealthtalk.live, because I have a lot of, and go to the bookstore because I have a lot of information, books in there around kids' anxiety, how to reduce anxiety, self-help books and stuff like that. So yes, keep in touch again through email, through my social media. Please add me on my Facebook, TikTok, Instagram, LinkedIn, everywhere.
Super. Really enjoyed the conversation. It's nothing better than, this is a good conversation for a lot of people to hear. And I think maybe another subject we can touch upon is one that John already touched about. People with disabilities go through a lot of issues because of the disability. And there's a difference between somebody who was born with a disability or somebody, in like in Monique's case, who acquired it during her life. So, and dealing with that in your mental health cases, situations too.
Yeah.
So go ahead.
I'll say something just about that, like whether you're born with disability. There's research out there about, you know, how it's really important how a child born with a disability is treated, right, as to how they're act right around the disability, right. So it's really important how the parents
address and deal with that and normalize those experiences, right?
And in addition, like I said, somebody who acquired it, like in Monique's case, where not only you're only dealing with your own depression because of what you're going through, but you're also looking at yourself as a burden to other people. So
There's also, Ken, the question of when you acquired it, because children who get disabled very early on have a different coping mechanism to somebody who gets, shall we say, a spinal lesion at the age of 30 or something like that. There's
Right.
that. There was also a very interesting comment I noticed coming up from Dr. Aderinka saying about nurture and nature, and also about chemical imbalance. Another area which could actually be tackled as well is, which I haven't even talked about today, is getting depression with postpartum.
There you go. So, and that happens too. It's a whole nother subject.
Yeah.
We can cover it another day, but it's a fascinating discussion and a lot of people need to hear about, need to talk about. So, okay, thank you all very much. Much appreciated. Thank you for coming. And we have not heard the end from Dr. Rogers. We will have other things with her in the future. So thank you. And thank you, Dr. Rogers, for taking the time to do this.
Oh my gosh, thank you so much. It's been a true pleasure.